Good evening, one and all. We'll be starting our session in 10 minutes at 6:30.
Very good. I'll be here. I'm ready. Thank you.
Yeah, Professor Ronald, welcome.
Thank you very much.
We'll be starting in 10 minutes, Professor.
Okay, I'll just wait here. No problem.
Uh, Thank you. Good evening, one and all. We welcome you to the International Webinar Series on Holistic Health, Well-being and Sustainable Development 2022.
Thank you very much. I'm happy to join you. Shall I begin?
Yeah, let me introduce you, Professor. We'll start with the prayer and then we'll move on.
Okay.
Just give me a second. Yeah, good evening, one and all. Welcome to the International Webinar Series on Holistic Health, Well-being and Sustainable Development 2022 on occasion of National Doctors Month 2022, commemorating Azadi Ka Amrit Mahotsav, nation celebrating 75 years of independence, and UN Sustainable Development Goals 2015 to 2030, in collaboration with Sri Holistic Health Foundation India and Sri Research Institute and Center for Art, Sciences and Well-being. Before we start our session, let's take the blessings of Almighty.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
With the blessings of Almighty, we shall continue to today's session. Today we have with us eminent speaker, Professor Ronald R. Donnell. He is clinical professor, program manager, international program, senior, global future scientist, Julie N. Wegley Global Features Laboratory, Arizona State University, College of Health Sciences, USA. Dr. Donnell is a clinical professor, psychologist, and also founding director of the Doctor of Behavioral Health program in the Arizona State University. He is a senior global future scientist, Julianne Wrigley Global Futures Laboratory, and has been providing lecture, consultation, and training on integrated care in China, Southeast Asia for over 10 years, and now in Bangladesh and in India. He is principal investigator on research grants studying integrated health in Thailand, Vietnam, and Cambodia, and a social worker training program in Arizona. He is collaborating with colleagues in Vietnam, China, and India to develop a curriculum to develop a new workforce of social workers for integrated care. We welcome you, Professor Ronald R. Donnell, and we invite you to take over for your session, the 5 A's: assess, advise, agree, assist, arrange, approach to patient management, engagement, and treatment. Over to you, Professor.
Dr. Ravindra, thank you very much for the introduction. I'm very pleased to be here. Good evening to all of you. I also share good blessings, and I share good wishes for independence celebration in your country. So just to remind people, my interest is in integrated healthcare. And that means, how do we have a new workforce of clinicians who are experts in all aspects of health behavior. They can talk to patients about education on what is diabetes, what is hypertension, why is medication important. They can talk to patients about lifestyle change. How do you eat a healthier diet? How do you get more physical activity to reduce or avoid obesity? How do you stop tobacco smoking? How do you stop overuse of alcohol? And of course, mental health problems. How do you cope with and prevent depression, anxiety, post-traumatic stress disorder? So in the United States, for the past 10 years, we're having many clinicians now work in the family doctor clinic, social workers, psychologists, other health professionals become the behavioral health experts in these settings. And when the doctor treats the medical problem, they say to the patient, please see my social worker. She will help you with your weight loss plan and your depression. And the social worker is right there in the primary care clinic or the hospital. So that's my US-based work. And I've been working the past 10 years to add this model to China, Southeast Asia, and now South Asia, India, and Bangladesh. And of course, it's not easy. There are many differences, right? But there are many similarities too. 10 years ago in USA, there were very few social workers working in primary care clinics. Now it's more frequent. My work in China, I've helped to train social workers to work in primary care clinics there for the first time. And doing the same work now in Vietnam and also in India. So that's my goal, is to create a new workforce. It could be social workers. They're well suited because they have good clinical training for the clinical social workers. There already are hospital social workers in India. So they have good basic training to learn these new skills. I'm looking forward. I know some of you I recognized from my last talk 2 weeks ago. It's good to see you here again. And today my talk is about an approach to assessment, engagement, and treatment planning for patients called the 5 A's. It's really an approach to be used for any patient and any kind of problem to organize your thinking and your planning. How do you first meet the patient and screen them to see what kind of problems they have? How do you assess in more detail the results of the screening? How do you offer the patient advice? And how do you, most importantly, reach agreement with the patient? How do you have the patient agree to a plan sincerely and honestly? A big problem we have is the patient may see the doctor and the doctor says, oh, you have hypertension. You need to take this medication and stop smoking and reduce alcohol. And the patient in front of the doctor may nod their head, okay, but they walk out the door. They don't fill the prescription, they throw it away. They don't change their tobacco smoking. They don't change their alcohol. They think, I don't have any symptoms. I feel fine. I have no hypertension symptoms. I'm not worried about this. I can't afford the medication. I can't change my habits. I like to smoke. I like to drink. So if we don't have good engagement and the patient agreeing, we have failure. The patient won't follow our advice and recommendations. And the 5 A's is an approach designed to improve and address that problem. So I'll share my slides today and go through them, and we'll take it from there. Just one moment. Okay, is my slide visible to all of you?
Yes, Professor.
Very good. So this is the 5 A's behavior change model. It can be used for educating medical problems, lifestyle problems, and behavioral problems. Any problem that the clinician wants to work with the patient to change a behavior, this is a good model to use. And here's simply the 5 steps. The first, of course, is to assess what kind of problems the patient is experiencing, looking at their risk factors. Do they have high blood pressure? Do they have high cholesterol? Are they depressed? Are they having very low physical activity? These are all things we want to try to do in our assessment. And we often use screening tools. I'll talk about that later on. Medical screening tools would be cholesterol, blood pressure. Behavioral screening tools would be the PHQ-9 questionnaire for depression. We get the information from the questionnaires, then we ask the patient more detailed questions to confirm the diagnosis. After we assess the patient, we give them feedback. We say, based on my assessment, here are the problems you have. You seem to be drinking alcohol in a way that's unhealthy. It might lead to health problems. You seem to be overweight, and that can lead to hypertension, diabetes. You're smoking tobacco. We know that's a risk factor for oral cancer, lung cancer. Here's my advice to you. You should work on approaches to improve your physical health by eating healthier, exercising more to reduce your weight and reduce your obesity risk. You should work on stopping smoking by cutting down or quitting smoking. You should work on reducing your alcohol or cutting down or quitting. I know these are many difficult problems. Which problem do you think you want to work on? So you're already giving the patient a choice to choose a problem, and then you can talk about an approach to use. So that's the advise phase. You give them advice. Here's the problems I see in my assessment. Here's recommendations. What do you think? Is this a problem from your point of view? You give the patient permission to talk to you about, are they interested in addressing that problem or not? Once you agree with the patient, you talk about a treatment approach. We want to use exercise for your obesity. We want to use smoking cessation based upon nicotine patch or nicotine gum replacement for nicotine, if that's available. So you give them options for treatment, and ideally the patient will pick one problem and one approach to begin with. I agree to start working now for the next few weeks on increasing my physical activity by walking, by going to the local park and walking there. You have a clear plan the patient will work on, and that's the assist. The assist means making a treatment plan with very clear instructions for the patient to follow, to go home and do exercise, to monitor their weight every day, to do things to take steps with your help to manage their health. And the arrange means your follow-up visit, maybe to have them come back and see you in 2 weeks, maybe doing a phone call or a video chat in 2 weeks rather than in person, to see how they're doing with their plan, to check in, give them encouragement, check their motivation. So the 5 A's is used from the very beginning to assess the problem, to engage the patient, to have them agree on a plan, and then to assist with a treatment plan they agree with and to arrange the next steps. It's a flexible model and it's patient-centered, meaning the patient is the center of planning, they're involved in planning. We need to have brief assessment because there are so many patients and so few clinicians. We must do effective short interventions that work. Shared decision-making means the patient and clinician, they share in decision-making about the treatment plan. The patient's an active partner. This is very different from the more traditional medical model where the physician or nurse simply says, my advice is to take this medication for hypertension. Here's your prescription, please go fill it. End of conversation. For some patients, if they're motivated, that approach is very effective. So if the patient is ready for change, agrees to treatment, the brief directive intervention is good. But for many patients, we know they're not motivated. They have ambivalence. They aren't sure they want to address the problem. And they often don't tell the doctor that they're not really on board or in agreement with the treatment plan. So it has to be a good approach for a busy clinic or hospital setting. I know, of course, in India, many social workers work in the community. They go visit the patient in their home or in the community centers. This can be used there also. It supports patient condition self-management. We want to teach the patients how to manage their own health without having to see us for appointments. Can the patient learn to every day monitor their weight, work on monitoring and improving their diet by adding healthier foods, reducing fattier foods? Can they monitor their alcohol and drugs to see they're going down? These are all things they can use, maybe even using smartphone apps to help them track their exercise, using a smartphone app for relaxation exercises. We want to give the patient the tools to learn every day I must manage my own health. And it's a lifetime process. It's not going to be done in a few weeks. It's a continual way of looking at my life, my emotional and my physical well-being and happiness. How can I do this on my own so my health gets better or I avoid having my health get worse over time? Here's some typical problems we can use the 5A's approach for. Non-communicable diseases like diabetes, hypertension, medication adherence, a very big problem globally. Improving nutrition, reducing high salt foods, reducing foods that have lots of fat, adding foods like fresh vegetables, fresh fruits and grains, whole wheat grains. Increasing physical activity, reducing sedentary behavior. We're seeing globally more and more of us spend time in our desk behind a computer. We spend time in our free time looking at our social media platform or streaming movies or shows. We're doing things that keep us from moving, and nothing wrong with technology, right? I love social media. I love to watch movies and series, but I also make sure I have a balance. So I'm doing physical activity as well as enjoying those kind of electronic relaxing activities. Obesity is a major cause of hypertension, of diabetes, heart disease. So we have to work on addressing that. And of course, the same for tobacco. I use the word behavioral to talk about psychological and substance abuse problems. So stress, very common. We're all feeling stressed out. COVID-19 has created global stress. We're all feeling more anxious, depressed, even traumatized by COVID. People are often resorting to more alcohol use or drug use. People are being traumatized. They're losing their jobs, losing loved ones because of COVID-19. So even before COVID, these were problems. Now with COVID-19, all these problems have increased globally. You can use the 5A's for a single problem. Maybe the doctor sees the patient and wants them to stop smoking, so you just work on the smoking only. It can be used as part of a formal health risk assessment. A health risk assessment is typically a questionnaire, maybe 20 or 30 questions that cover many different types of health problems. I've used one of my research in Asia that covers depression, anxiety with the PHQ-4, post-traumatic stress disorder with a short questionnaire, nutrition questions about fruits, vegetables, salt intake, sleep questions, are you sleeping well? So you get to do it like once a year, an assessment to see all the kind of problems the patient experiences, and then to work with the patient on that assessment to pick one or two problems they want to work on first. And the common focus, again, is patient-centered, to have the patient involved, working with you to agree on the treatment approach you're going to take. Here's a simple diagram of how the 5A's works. You can see for yourself, and I'll make the slides available to my colleagues so you can share with you. We assess the different risk factors. We advise the patient based on the treatment approaches that are available to them. We reach agreement to collaborate on a treatment plan and goals and how to move forward. We do the assist to help develop a treatment plan that lists the goals clearly in behavioral terms, what kind of techniques they're going to use to change their behavior, a follow-up plan, to change health habits, to reduce smoking, to eat healthier. It doesn't happen quickly. It takes weeks and months, often at least a few months, sometimes up to a year. And it requires the clinician to follow the patient up over that time period. Maybe at first in person in the office, but later on, or in the community, later on by doing text chats, phone chat, video chat, if the patient has that capability on their phone. But the goal is to help the patient over time, again, learn to manage their own health on their own. Arranging for a follow-up. Can they go to a local health center? Can they look at the website for information about their problem? Can they get a smartphone app to use to help monitor their health? This is the cycle we use for problems with the 5A's. I know it's very common in many countries, including India, where the patient's partner will also attend the medical appointment, their spouse, their wife, and that's good. And when that happens, we want to include the spouse or the partner in the treatment plan. They should be invited to sit down. As you ask the patient questions, they can offer their input about what the patient's eating at home, about their smoking and drinking. Certainly, other people are involved, friends, adult parents of older adults can be involved. Whoever's present, had them all engaged in the treatment planning. You can involve the partner ask them questions directly to make sure we're all on the same page. If the patient is a man and the woman is with him, his wife is with him, and she's the one doing all the cooking at home, she must be involved if the goal is to improve healthy eating, right? She must be the one helping to work with the patient and the clinician on a new shopping list to bring more healthy foods home, to have foods that are still enjoyable, but they're healthier and reduce risk of hypertension or diabetes. So it really is important to include the partner or caretaker in all steps of treatment planning when possible. It's always nice to ask permission before you start talking to a patient, because we know stigma about these problems is very great globally. United States, India, patients are often embarrassed, ashamed to talk about depression, anxiety, their obesity, their nutrition, their alcohol. They may not want to address these problems. So if you simply ask the patient, is it okay if we talk about the survey you just completed, talking about your mood and your physical activity and your nutrition? You want to be non-judgmental and curious, not lecturing, not warning or punishing, not scaring the patient off, but inviting them to share their habits and not to be seen as pushing them or making them move too quickly. We want to avoid stigma laden terms. I often recommend when you're talking to patients, if you think they have a strong stigma, not to even mention the word depression. Talk about stress symptoms or stress illness. People don't mind talking about stress. We all are stressed out. And we know, depression, physical symptoms are often the key for depression, right? They're the things patients experience. I feel tired. I can't sleep well. I have a stomach ache, headache. My muscles are tense. These are all what the patient experiences, thinking they might be medical problems, when in fact they're often caused by stress problems. We want to listen to the patient, give time to focus on what they're saying, how they're describing their symptoms, use their language, observe their facial expression, their body language. As you're giving advice, do they seem to be interested, or do they seem to be dismissive? Are they looking at you in an engaged way like this? Or are they looking away, looking down, avoiding eye contact? Look for clues to how interested they are in the kind of approach you're talking to. Look at their tone. Do they seem interested? Do they seem excited? Do they seem bored or defensive? It feels good to be understood. So reflection simply means you reflect back to the patient in using your own words to describe their words, what they're telling you. Oh, you're telling me that you're having difficulty sleeping, you can't fall asleep because you're worried, and you wake up and you're tired all day. You're repeating back in a very factual, neutral way what the patient is telling you. This shows the patient you're listening. It shows them you understand the problem from their perspective. And that's a good feeling. If we don't listen to the patient and show them we're listening, they often don't trust us. So the first phase is to assess the patient health risks. If it's a new patient, you want to do a thorough assessment of all the kind of health problems they're having, maybe using a health risk assessment questionnaire. You want to get the patient, after your assessment, explain what the results were. My results show that you have obesity, meaning compared to the average person, your weight is much higher. We know if you have obesity, you have risk of all kinds of problems in the future, such as diabetes, hypertension, joint problems like arthritis from too much weight on your knees. So we can explain the risk they have. We can explain what kind of treatments are available for the problems they have. So we want to assess the patient by asking more questions, getting more details about the problems, about the context of their problems, how the problem is at home, at work, what kind of role their friends play in the problem. Many people engage in unhealthy behaviors like smoking or alcohol with friends in social settings that are very enjoyable to them. So it's important to get information from the patient's perspective about all aspects of the problem, not just what's bad about the problem, what the problem is, what's good about it, what kind of things it helps them in their life. Tobacco smoking often helps people feel more relaxed and more able to manage stress. There are benefits of some of these bad behaviors. And lastly, we want to assess the patient's motivation to change. I do another training on motivational interviewing, where we basically ask the patient, okay, how ready are you to change this problem, to work on this problem? On a scale from 1 to 10, 1 being not ready at all, 10 meaning I'm very ready to work on this problem. What's your readiness to change? How important is this on a scale from 1 to 10? How confident are you in your abilities to work on this treatment plan to be successful on a scale from 1 to 10? We can get a sense of, is the patient really ready for the approach you're recommending? If they say they have maybe 7 or 8 out of 10 on readiness, 7, 8, or 9 on motivation, interest, we know they're ready to move forward. If they say, oh, I'm only 1 or 2, that tells you what you're recommending, that they aren't ready for that yet. And you have to think of a different plan that they have higher confidence and readiness in. So motivation interviewing means to find out where the patient is for readiness and use that for planning. Advising, again, you give the patient feedback about all their risk factors, about their blood pressure, about their cholesterol level, about their depression, their physical activity. And again, offer a menu. Think about going to a restaurant. You open up the menu, you have all kinds of choices. We should give our patients the same menu of choices for the problems they're experiencing. Well, you have depression. We know depression, there are several approaches. Antidepressant medication is one. Here are the pros and cons of medication. Using psychotherapy like cognitive behavioral therapy or behavior activation is an approach. Here's how that approach works. Here are the pros and cons. Physical activity, exercise can help depression. So you give them choices and have the patient talk about and think about the best approach based on their interest, their values, their lifestyle. And once they choose an approach, you can give advice that's more specific and move forward with a plan. And that's the agree phase, where you talk about the options for treatment, the patient chooses an approach, you move forward with a commitment. The patient will work on this in the weeks ahead. And that takes us to the assist phase. We start a treatment plan in this phase. We develop a treatment plan with the patient where they're going to work on certain clear goals. I'm going to every morning spend 15 minutes walking up and down my stairs for exercise. I'm going to spend every afternoon half an hour walking with my partner to the local park for relaxation exercise. You make a clear plan they can do that will be their homework, that they commit to doing at home on their own and with help from their partner, ideally. So it's an action plan. And you agree to have goals. Okay, I'm going to exercise 5 days out of the next 7, each time 15 minutes. I'm going to meditate after my breakfast every day for 15 minutes. For the next 7 days, I want to do at least 6 days. So make a very clear goal for the patient to be able to set for themselves and set reminders to do that goal. That's the assist phase. We want to use SMART goals. You may have heard of this. Goals that are specific, measurable, attainable, realistic, and time-based. So on the right-hand side are examples. I'll walk at least, so many minutes, so many steps, so many days over the next week. I'll eat so many servings of fruits or vegetables added to my diet over the next 4 weeks. You're having very clear plans you can measure. So when you call the patient up or talk to them after 2 weeks, 3 weeks, you can say, well, your goal was to walk 10 minutes, 5 days a week. How's that going? Are you being successful? If they are, you want to encourage them to keep on doing or add to that. If they aren't being successful, you want to use problem solving to figure out what is the problem that's keeping you from being successful and work with the patient on that. Arrange means at the end of the meeting, the first meeting, you simply have clear steps. The patient's going to plan to go home and do things on their own. They might want to go to visit a website you give them about information, maybe give them a brochure about the problem you're talking about, have them read that, maybe work with their partner, their spouse to work on the problem. If there are any kind of education groups around, a group on depression, a group on diabetes management, the hospital offers, have them go to that. So have them plan the next steps as well as coming back to see you, the clinician, again. These are all part of the arrange phase. So I'd like to hear just for a few minutes, I'll pause my slide share. How does this model sound to you? And what kind of questions do you have about this model? Some of these things I think you're doing already, some things I'm not sure you're doing. So Let me take a few minutes of a break here. I'll stop sharing. And just tell me, what do you think of this approach? Does it make sense? Does it seem unrealistic? I should say the 5 A's can be used by different clinicians in different ways. There's a very short version of the 5 A's for physicians to use it in a 2 or 3 minute visit to do a brief version of this. But typically it takes a behavioral clinician, a social worker, a counselor, a nurse, about 20 minutes to 30, 45 minutes based on the patient to go through the steps and complete this in one visit. So let me stop, and any questions or thoughts from you? Anybody using this approach or something like this already? Let me stop and hear from you. Thank you.
Yeah, Professor.
You can use text chat if you don't want to talk. You can also chat any question, but if you have a question or comment, I'd like to hear, what do you think of this approach? Does it make sense? Does it not really make sense for you? What kind of questions do you have about it?
Participants, feel free if you have any comments, observations, or any queries. You can unmute yourself, or you can raise your hand, or you can put in chat box. We'll be happy to answer.
Actually, it is really applicable in life, Professor, all the 5 years. If you apply it, it will be great. But the problem is we have not applied. We should yet to apply in each part of our life.
Yes, of course, to do the 5 A's, it means you must have training and competency in all the steps at each step along the way. If you want to do the assessment, how do you do a screening questionnaire, right? You have to have that skill. If you want to give advice, you have to be able to give advice about what are recommendations for diabetes, for hypertension, for depression that are available with you or in your community, right? You have to know these skills too. So the 5 A's is a framework that requires deeper knowledge and competency to use it. You're exactly right there. So it can be tailored to the kind of skills you have. If you're a clinician and you know how to do cognitive behavioral therapy, that can be your main approach for depression, for anxiety. But many clinicians need to learn some new skills to be effective with this. So thank you, Mary, for that feedback. I see from Javier, if a patient's caregiver has a sad face, what effect will that have on the patient? Will it take longer for the patient to recover? That's a great point. So I mentioned it's always good to have the patient's caregiver or spouse or partner with you when you do this 5 A's assessment, because they're part of the patient's life. They're often there when you are not. You might see the patient for half an hour, 1 hour, once every 3 weeks. Their caregiver or partner sees them every day, 24/7, right? So you want to see if they have a sad face. I would say, gee, you seem kind of sad now. What are you thinking? What's on your mind? Give them permission to talk. And oftentimes after you give permission, they will talk more and more. And you have to find out what they're sad about. Are they sad because they've been telling their partner to stop drinking alcohol for a long time with no effect? Are they sad because they don't want to change their cooking habits to eat healthier food? All kind of reasons, but you're exactly right. You must have that caregiver or partner be an active member of the treatment team. You're the clinician, the patient, and their partner must be involved for success. Otherwise, the odds of changing habits are very low. And once the caregiver or partner is on board, they can encourage, they can support the patient in trying to make these difficult changes. I hope that was helpful, Javier, for answering your question. Any other questions or comments? Okay, I'll go back to sharing my slides and finish up my presentation. Just a moment. So again, I know in the United States, we have clinicians working in the primary care clinic. I know that's not the case in India. We have many social workers, for example, in hospitals. And these can be used certainly by doctors and nurses too. It isn't just social workers and counselors. Any kind of health professional can learn these. You can also train community health workers, volunteers, right? Even former patients who are managing their health better can become health coaches with training. That's often the case in many countries. I know India, Thailand, they have many health volunteers, people living in the community that can be trained on these approaches, supervised by a doctor, nurse, social worker, and even run, for example, once a week, a group in the community on healthy living, things like that. So this can be modified for your country and your settings. And of course, it's more difficult based on the kind of patient population. If you're working with patients who are in rural areas, who are very poor, who are just trying to survive day by day, it's hard to talk about some of these things because they can't focus on anything more than their day-to-day survival. You can't talk about adding fruits and vegetables if they can't afford them, right? So you've got to adjust this approach and do what you can based on the patient's living situation and circumstances. Here's just an example of how long it takes to complete the different steps. Identifying the problem can be very short. An assessment, 3 to 10 minutes. Summarizing your understanding and giving the patient options, 2 to 5 minutes. Reaching agreement often takes a little bit longer, 2 to 10 minutes. A treatment plan, 3 minutes to 10 minutes. And then arranging next steps, 2 minutes to 10 minutes. So it can be as short as 5, 10 minutes. It can be as long as 40 minutes, even an hour, based on the kind of problems the patient has. But my key point is this can be modified based on the time available the clinician has. A busy family doctor maybe can just spend 5 minutes with the patient. They can use this approach for a few minutes and still have benefit. A behavioral health clinician, a social worker, a psychologist can have more time and do a more thorough assessment. More is typically better, but we realize more often is not available, and shorter can be done too. Here's a sample script a clinician might use. Hi, I'm your clinician. I'm a social worker. I'm a nurse. I work with the medical team. I help to address health behavior change, any kind of thing about your physical habits, your emotional health, your nutrition, your lifestyle, managing your chronic illness. I can help with all these things. Anytime your doctor wants to talk to me, I can talk to your doctor about the challenges you're having. So ideally, the clinician is working with the family doctor. I know that might be a challenge in India where the social worker or other clinician is not working with the family doctor, but that's ideal. So the family doctor knows if you're a behavioral clinician working on the patient's nutrition and physical activity to help them manage diabetes, the doctor should know that. If you're trying to help the patient medication adherence, you have to talk to the doctor and tell them, gee, the patient thinks they have too many side effects. Can you offer different doses, different kind of medication? So ideally, the behavioral clinician will talk to the family doctor or nurse to communicate as a team, even though I know it can be difficult in India. You might say, I see that your doctor wants you to work on managing stress. Do you agree with that? What kind of stress do you have? Give examples of stress, then begin your assessment. So you want to make a connection between the referral, if you got a referral from the doctor, what their problem is, making sure you're on the same page with the patient before you proceed. If we have time, we do a biopsychosocial assessment. We take time to find out about physical symptoms, looking at the medical record, their labs, a behavioral assessment. What kind of behaviors are they engaging in to manage depression, to manage their hypertension? Their cognition, what kind of thoughts do they have? Do they feel positive? Do they feel negative? Do they have negative thoughts that help them, to stop them from going forward? How's their emotional reaction? Are they very dedicated and positive? Are they very fearful and anxious? Those are all things to think about, the thoughts they have. If a patient thinks, oh, I cannot change my habits, it's too difficult, you have to work on helping them change their thoughts to get more positive. And of course, their environment, their type of work, their home environment, their social support, their partner or caretaker, what is their role helping the patient? So biopsychosocial, you're looking at the biology, the psychology, and the social environment of the patient. Functional impairment means how does their problem impact their day-to-day living, whether it's doing their chores and errands at home, cooking, taking care of shopping, taking care of cleaning the house. if they have a job, going to their job, being effective on their job. How does it affect the family? Does it affect their relationship with their spouse? Does it affect the relationship with their parents or children? What kind of changes in activities? Are they becoming more withdrawn and not going to do things they used to do, like going to church or going out with friends because they're too depressed? Any changes in sleep, energy, concentration? The role of things like caffeine and sugar. How much are they taking? How much alcohol? Any medications or supplements they're taking? Are they involved in Ayurveda medicine, taking any kind of medicines like herbs or home recipes to help their health? So you want to find out what their impact is of the problem in their life, what they're currently doing to try and improve the problem. What are their current efforts? What are they trying right now? So this is really part of a functional assessment. Common tools for assessment: look at the medical record for their weight, their body mass index, their waist circumference. We look at their blood sugar with their fasting blood sugar or HbA1c for blood glucose. And we have questionnaires often to start off, questionnaires for depression, alcohol, stress. Maybe all these questions are involved in one long health risk assessment, 20, 30 questions. And once you do the screening questions, you can score those, and you can then talk to the patient about the ones that seem to be a problem, and check with the patient. This indicates you seem to be depressed. Depression is feeling of low mood, feeling of lack of motivation, interest in things, maybe having poor sleep and fatigue. Do you think you're depressed? Do you think you have stress symptoms? You check with the patient and interview about the screening results and make sure that they make sense from the patient's point of view. Then, of course, we summarize. You summarize to the patient your understanding. Based on our talk, it seems you also agree you have problems with overeating, you're worried about your weight gain, you think you might be drinking too much alcohol, especially on the weekends. These are things that you summarize what the patient tells you and they agree with, so the patient knows you're listening. The patient can confirm you're on the right track addressing problems they want to address also. So you give a summary based on your assessment and say, is this right? Is there anything I missed? What do you think? You want to summarize and then give your advice. In the agree phase is to, when you summarize and pick the problems the patient wants to work on, you offer options, the menu I told you about. Offer the plan of action, offer the treatment approach the patient agrees on, and then begin talking about next steps. You want to take medication, you have to get the medication prescription filled. Can you afford the prescription? Do you have the money for the prescription? You must take it, once a day, twice a day, making sure they understand all the aspects about the approach they're taking. Agreement is agreeing on the goals. I mentioned using SMART goals. So the patient really has clear goals they're going to work on. They can think every day, am I achieving my goal or not? Making the goal every day something they think about. In my life, for example, every day I want to do mindfulness meditation for 10, 15 minutes in the morning. So I have in my schedule, I'll have my breakfast, then I'm going to meditate for 10, 15 minutes every day. So it becomes part of my routine to manage my own stress. And I find just taking 10, 15 minutes to focus on breathing, imagining my stressors, my thoughts, observing those, planning my day is very helpful for me. So those are examples of trying to have goals you set for yourself to make them habitual. When you have the patient involved, they have more control when they agree. They feel like there's something they're agreeing to and they have belief in. It's based on realistic goals. What can I really achieve? I'm not going to go out and spend an hour exercising. I can do 10 minutes though. So pick realistic goals. And it ties to the patient values and beliefs, the things they believe in. These are all things that share decision making that make the probability of success much greater. You want to have a clear follow-up plan. When will they see you again? When will they see their doctor again? Do they have any community supports they can use? Is there a social worker going to the community who can visit them once a month to help reinforce these things? Can they use a website or a smartphone app daily to help them on these problems? So have a very clear plan that is very detailed for who they'll see, when they'll see the next person, when they'll come back again or contact you by phone or text. And assist, of course, you begin the patient's treatment plan, working on the plan they have in place and checking in over time. Are they being successful? So oftentimes the patient might be motivated at first and lose motivation. Maybe something happens in life that's stressful and they fall off track. So you have to have check-in with the patient to make sure as their life changes and things become more stressful, they can still keep their goals intact. So again, arranging is making sure they have smart goals, a strategy. I use, for example, a little calendar where I write my daily goals I want to work on in my life so I don't forget. These are things you can have the patients do to have them be more successful. So in summary, this is the 5 A's. It's used very often as a way to assess the patient problems, offer advice, reach agreement, and create a plan. So we all do this with our patients. If you're seeing patients, you always do an assessment, you always give advice, you always make a recommendation, but oftentimes we don't do the agree. We don't spend time with the patient making sure they really agree with the plan. And we find when we stop and take the time, that really helps the patient be more engaged, more motivated, more likely to actually walk out of your office and do the things you agreed to instead of walking out and not doing anything you talked about. So this is the benefit. It takes a little extra time to add this component, but it really is one that helps the patient be more successful. I'm going to stop now. We can finish up the next 10 minutes, I think. I have another meeting coming up, so I'll stop sharing my screen. So that finishes my talk for today. And I hope I can come back and do more talks about some of the components. How do you do a health risk assessment? How do you do motivational interviewing? I can talk about those problems also. So this is just really an introduction to this topic. I hope it's helpful for you. I will make the slides available. I'll give you my email. If you have any questions, I can send you information. I have many short articles describing the 5 A's approach. So I'm happy to share more information if you like it. Happy to take your questions and hope I can come back and talk about these topics more. So I'll stop there and there's time for any questions or comments now. Thank you.
Thank you, Professor.
You're welcome.
Participants, feel free to share your comments, observations, or any queries, if any. You can unmute yourself or raise your hand or yeah, Mary.
Hi, Professor. Your talk was really informative and lot of learning from me. And this is a new concept, so I learned details. If I get more chance, I will go through it. It's more learning for me. And it's a very good presentation, Professor.
Thank you, Mary. I appreciate that feedback. Thank you very much.
Yeah,
I see-
Adrian. You can unmute
Hello,
yourself.
sir.
Yes.
Hello, doctor.
Hi, Adrian.
Hi, sir. I just wanted to ask if we'll be having a certificate right after attending this webinar.
If I have, I couldn't quite hear your question, Adrian.
Will we be having an electronic certificate right after we attend this webinar?
That's a question for Dr. Ravinda to answer. I don't do
Yeah, we
certificates.
will be providing certificate to all the participants who are attending, who have registered, attending, and also filling the feedback form.
All right. Thank you so much.
Thank you.
You're welcome. Thank you.
Yeah, anyone else would like to share? Feel free to discuss. It was really nice presentation, Professor. Actually, we are implementing this, but I think, I mean, we need to study in detail this model and further. These 5 ways are also used. I mean, generally when a client comes in, we take case history and then we do the assessment and then we also assist him. I mean, what could be the next course of action or the treatment. And then we arrange for the formalities, and also if there is any requirements like finance or any financial support or social support, economical support.
Mhm, mhm.
And then there are follow-ups. So I mean there is similarity, and the differences we need to find out maybe in detail. So if we can have a more detailed session, maybe in that session, after going through that, we find more similarities, and but differences, at this point of time it is very difficult for me to share about differences, but maybe if I can look more into it, then I can share into any major differences.
Yeah, I appreciate that feedback, Dr. Ravinda. And yeah, like I said, we already do these things. If you're a clinician, you're already trained in doing an assessment and giving advice and doing a treatment plan. This is just a way to incorporate the patient-centered approach, the shared decision-making, where the patient is more actively involved. And again, if the patient is already very compliant, there's no need for this to be used, right? The patient agrees and goes out and takes medication, increases exercise, because we're physically active, that's great. But many patients we know are not motivated, they're ambivalent. They know they should change, but they can't break their habits or to make these changes. So those are the patients who need this more thorough approach. But the benefit is, rather than just having those patients go off and be non-adherent and not take care of their health, we spend the extra time, they're more engaged and more likely to go ahead and do things to actually improve their health over time. So it's an investment that takes more time, but the return on investment is healthier patients are more successful.
That's nice. I think we can plan and collaborate a workshop for the social workers. Maybe that will bring more, disseminate this information, and also bring more inputs and feedback from them. Maybe
I'd be happy to. I'm doing training right now on this topic for the social workers at the Cyber University School of Social Work in India. We're meeting every 2 weeks doing more detailed training on these kind of approaches. So we can talk, Dr. Ravindra, sometime about maybe doing some collaboration together in the future. I'd be happy to do that.
Sure. Thank you, Professor. And there is one query, Professor. Let me read it for you. There are times that we find it difficult to assess a patient, especially when the person does not have any idea of what he is experiencing. What certain resolution can we provide in these cases? It's by Adrian.
Yeah, so if I understand correctly, many patients, they have problems, but they don't acknowledge or understand them. So a good example is people who feel stress. They might have, stomach ache, headache, fatigue, poor sleep. They think it's a medical problem. They want the doctor to give them medication. Give me a pill so I feel better. But in fact, they have to learn how to manage their stress. So in that case, you must educate the patient. Here's what stress can do to you. Stress can cause these physical symptoms. Explain the relationship between stress and physical symptoms. Education is key. Understanding, listening to the patient, right? If they don't think they need to change their alcohol or tobacco smoking, they don't think it's a problem, to be patient, offer education, to raise their awareness about why they should change. Give examples. Have you had any relatives in your family who died from tobacco smoking and cancer? Do you have any relatives who had diabetes and became blind or had to have their feet amputated? If they have an example, someone they know who had this kind of negative consequence, that can raise their own motivation. So the question you raise is about how do you increase motivation, and motivational interviewing is the best approach for that. And we can cover that also on a separate topic. Thank you.
Yeah, I think one example, one case study, one of our friend has said hemorrhage problem at the age of 65 years.
Schizophrenia? Yeah, I had much experience with schizophrenia earlier in my career, working with patients with that condition, and the same thing applies there. Now, if a patient is psychotic, it's more difficult. But still can be effective, right? So I worked in a psychiatric hospital with schizophrenia patients for several years. Individual therapy. A patient could be psychotic. I would just sit and listen. Whenever the patient talked about something that was positive about their health, whether it's physical health, mental health, I would suddenly engage. I would reinforce verbally their thinking about that topic. So slowly the patient learned my interactions. If they bring up topics that are about their health, I'd engage, I'd be very interested. If they were talking crazy about things, paranoid delusions, I wouldn't really engage as much. We developed group approaches. We developed education groups for schizophrenia patients based on some existing models that are out there where they get education about how to manage their symptoms, how to take medication as prescribed, how to manage stress, how to take care of personal hygiene, keeping themselves, clean, how to manage shopping and budgeting. So we gave them, even though they were schizophrenia with thought disorder, these kind of training programs.
Nice.
Those are examples that even schizophrenia patients can benefit from these kind of approaches.
Yes, Srinivas, hope it is answered. Otherwise, you can unmute yourself. Or you can put in chat box also. Yeah. Fine. It was a really insightful presentation, even the earlier presentation and now this presentation. Now it's creating more curiosity to learn more and explore more. It was a really wonderful session from your side.
Well, thank you all for having me today. Thank you for your patience and your questions. I enjoyed talking with all of you. I wish you a good evening, and I wish you can have some good success thinking about these techniques and applying them in the future. Thank you very much. My pleasure.
Thank you, Professor, for accepting and joining us. On behalf of Sri Holistic Health Foundation India and on behalf of Sri Research Institute Center for Art Sciences and Wellbeing, and also on behalf of all the participants, we wish you all the success for all future endeavors. And also, we would like to hear more from you for more sessions on various topics. Thank you once again for joining us.
Thank you. Bye-bye. I'll see you all next time.
Take care. Good night. Good morning for you.
Yes, and good night to you. Goodbye, my friends. Goodbye.
Dear participants, feedback form is being shared in the chat box. Kindly fill up the feedback form so that you can receive your certificate within 15 working days on the webinar series website. Kindly find the feedback form in the chat box. Yeah, just a second. We are sharing the feedback form. Yeah, feedback form has been shared in the chat box. Kindly fill up the feedback form before you leave the webinar. Daily, we are conducting various webinar sessions from 6 to 8 on various topics from eminent speakers across the world. So kindly do join at the same time, 6 o'clock till 8. And on Sundays, we have conferences from 11 to 5 on Sundays. Weekdays, it's 6 to 8 p.m. With the same link, you can join every day. Feedback form has been already shared in the chat box. I'm sharing once again. The first link would be feedback form. A link to join Telegram channel and Facebook has been also shared to receive daily updates and reminders. Kindly join the Facebook group as well as the Telegram channel so that you can receive daily joining links and update. The joining link would be same for every day for all the events, for even Sunday and all events. It's the same link. You can save it or schedule it in your calendar or reminders daily 6 to 8 p.m. IST Indian time, and on Sundays 11 to 5 p.m. So daily you will be provided with a certificate after participation. You kindly fill up the feedback form. We'll be there for another couple of minutes. We thank everyone, each and everyone for joining us. And on behalf of Sri Holistic Health Foundation India and Sri Research Institute Center for Art, Sciences and Wellbeing, thank you once again and keep joining us daily and gaining insights into various topics. Kindly fill up the feedback form shared in chat box. Certificate will be shared on the website. You can visit website and download certificate within 15 working days. Dear participants, kindly fill up the feedback form. Once you have filled the feedback form, you may leave the room. See you all tomorrow at the same time. Take care. Good night.